Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy, which is related to the splenic disorders in infant and children. Actually, this topic is very important for all pediatric surgeon and pediatrician. So let's start. It's an important topic related to all pediatric surgeon and pediatrician to know well what is the splenic disorders, how to diagnose, and how to manage. Let's see. Our objectives today will be related to the embryology and the abnormalities of the spleen, the anatomy of the spleen, and how this anatomy helps the spleen to function well. And we will speak about an important topics related to the spleen and the immune system. So all pediatric surgeons are concerned with splenectomy surgery. So all pediatric surgeons should know what's about the immune function and how the immune system may be disturbed after splenectomy. So please limit splenectomy to indications. Also, surgical approaches for the splenectomy, the different approaches and the complications, controversies related to these approaches. Let's see. The spleen is the largest and important lymphoid organ related to the bloodstream. It regulates the blood volume, it stores blood, stores platelets for trauma. It filtrates the blood, maybe act as a mechanical or biological filter to filtrate the debris and filtrate the malfunctioning or old RBCs from the circulations. Also, it can filtrate the organism, the viruses, bacteria. And also, it plays an important role in the immune system. It helps the innate and adaptive immune system. And we will discuss these items in details. The spleen nowadays become a focus of the surgical attention in children, mainly to control bleeding after trauma, to treat some hematological disorders, and to remove masses, cyst, tumors of the spleen. The embryology of the spleen is very simple. It develops as a mesenchymal pouch in the dorsal mesogastrium between the developing stomach and the pancreas. The spleen during fetal life is responsible for productions of the white and red cells. However, these functions stop later. Splenic abnormalities. Pediatric surgeons should be familiar with the splenic abnormalities. We may face with condition called asplenia, wandering spleen, polysplenia, accessory spleen, and splenic gonadal fusion, and also splenic cyst. Asplenia means no spleen. It's a complex problem, may be seen with other complex conditions like heart disease, bilateral right-sidedness, intestinal malrotation. Actually, the major problem here will be related to the absence of the spleen and its role in the immunity and the susceptibility for this infant to what's known as overwhelming infection. And the infant should receive antibiotics for prophylaxis. We may face with a wandering or mobile spleen. This may be related to the lack of the ligament that fixes the spleen in its position. May be related to the failure of the development of the ligamentous attachment of the spleen. The children may present with acute torsion and the infarction of this mobile spleen. The spleen may rotate around its vascular pedicle, become infarcted or present with acute torsion, severe abdominal pain, and abdominal masses. Some cases may present with pancreatitis. How to treat this problem? Usually we perform what's called Splenopexy, or fixation of the spleen, whether to put it in a mesh, to put it in a omental basket, extraperitoneal pocket, and suturing the spleen, maybe with absorbable, non-absorbable mesh to the upper lateral quadrant fixation. Some cases may need the splenectomy for the treatment of the wandering spleen. Especially in acute torsion and infarction, you should perform splenectomy. Cases of the chronic torsion associated with massive splenomegaly may be a candidate for splenectomy. There is a condition called polysplenia. What I mean by polysplenia? It's clusters of the small splenic masses instead of the single normal spleen. So the infant do not have a single normal spleen, instead have small splenic masses called polysplenia. Often this condition associated with other congenital abnormalities, biliary atresia, preduodenal, portal vein, situs inversus, malrotation, or cardiac defects. However, these infants have adequate splenic immune function. On the other hand, there is what's called accessory spleen. What mean? What's the difference? Here, there is a small nodule of the splenic tissue separate from the main spleen. So here, there is a normal spleen and accessory. However, in the polysplenia, there is multiple small clusters in the absence of the normal spleen. Very important difference. Affecting up to 30% of children. Usually, it's a mesenchymal remnant that fail to fuse with the main splenic mass, and 75 located near to the splenic hilum. The importance here of these conditions is that the presence of the accessory spleen may be affect the pathology for which the planned splenectomy performed. So the missed accessory spleen may be problem or lead to the recurrence of the primary disease, like in some cases of ITP, immune thrombocytopenic purpura. We will discuss it later in detail, and also in some cases of what's called hereditary spherocytosis. Splenic gonadal fusion. Sometimes the left gonad and the spleen are attached because of the early fusions prior to the descent of the testes. This attachment may be with a continuous band or maybe discontinuous band. There is a remnant of the splenic tissue attached to the left testis. Also, we may have cords in this band, remnant of the splenic tissue. Usually, this condition is treated with a surgical separation. Some cases may need to splenectomy, and usually we preserve the testis. Splenic cyst. We may be faced with a primary cyst or post-traumatic pseudocyst. And the difference usually related to the epithelial lining. And the primary splenic cyst related to the inclusion of the surface mesothelium to the splenic parenchyma. How to diagnose the patient with a splenic cyst will be related with the symptoms related to the cyst size. Huge cyst may cause compression on the stomach. There is maybe abdominal pain, mass. Sometimes maybe infection in the abscess. Sometimes, rarely, there is maybe ruptures of the cyst. The treatment will be related to the size of the cyst. Cysts less than 5 centimeters can be observed. Cysts that are enlarging, symptomatic, or larger than 5 centimeters, percutaneous aspiration and sclerosing, utilizing a different subject, may be reported with variable success. Sometimes we perform what's called marsupialization, commonly performed. However, if not performed adequately, there is a high recurrence rate. You should remove adequate wall of the cyst and leave the cyst open so these walls cannot oppose again and the cyst recurrent. And it's common with laparoscopic excision of the cyst because it may be partial excision and not complete excision. So you should excise the systole adequately so they can be opposed again and there is no recurrence. Sometimes we need to perform partial splenectomy, removing part of the spleen with the cyst. And also you should remove a normal margin of the spleen so that the cut surface cannot oppose again, which might lead to recurrence. Some surgeons involve lining the cyst cavity with a Surgicel or omentopexy to control or treat the splenic cyst. Now we will shift about to speak about the anatomy of the spleen and how this anatomy is helpful for the different functions of the spleen. The anatomical arrangement of the spleen is very important. As we see in this picture, there is what's called splenic white bulb, and there is what's called splenic red bulb. And in between, there is what is called a marginal zone. It's very important for all pediatric surgeons to understand this point very well. The red bulb is formed of splenic cords and sinusoid. There is network called the splenic cord or cord of Flores and sinusoids, and also there is a red bulb macrophage. Three important components for the red bulb of the spleen. As we see here, this is the sinusoids and this is the splenic cord. So the splenic cord is a reticular meshwork filled with the blood. And here the blood will move by the open circulation system. So the blood can transmit it free in these cords to be collected again by the sinusoid. This will help to trap the damaged RBCs, the malformed RBCs inside the spleen. We will see. Sinusoids. Splenic sinusoid is very important as they are long vessels with a fenestrated basement membrane. This fenestrated basement membrane allow only the normal RBCs that can be modulated shape to pass through this fenestration. However, the rigid RBCs, the abnormal shape, abnormal hemoglobin, the RBCs attached to the antibodies called opsonized RBCs will not pass through these very small slits or fenestration in the splenic sinusoids. So this fenestration or slits is very important. Allow only the healthy RBCs, the flexible one, to modulate its shape and pass through these narrow slits. The red bulb macrophage. It phagocytoses the damaged RBCs or platelet that don't re-enter into the venous circulation through these slits. So also it captures the viruses and the opsonized pathogens. Pathogens, virus or bacteria attached to the antibodies called opsonization process of coating the viruses or coating the microorganism with an antibodies to be known and identified by the immune system. So these red bulb macrophage will phagocytose these opsonized bacteria or viruses, preventing them from returning to the circulation. So the spleen here acting as a biological and mechanical filter, preventing this substance from re-entering the circulation again. The white bulb. White bulb usually concerned mainly with the immune function. There is a very arteriolar lymphoid sheath, what's called PALS, which is rich in the T lymphocyte. T lymphocyte is a subtype of the white BCs or leukocyte. We will discuss. So here, the blood will pass first through the white bulb. During the passage of the blood, there is a T lymphocyte, there is a macrophage, there is a lymphoid follicles, and there will be what's called antigen-presenting cells will present these virus is present to the T lymphocytes, and the T lymphocytes will activate the B lymphocyte to change into plasma cells, produce an antibodies for this organism. So here, the site for the immune response, very important to be understood for the pediatric surgeon. Imagine when you remove the spleen, you will remove this immune response. And some bacteria, especially the encapsulated bacteria, can pass into the circulation, causing overwhelming sepsis or infection to the infant or a child. The marginal zone is the zone here between the red bulb and the white bulb. It's called MZ, or the marginal zone, transitional zone between the red and white bulb, contain what's called antigen-presenting cells. Cells like the dendritic cells and the macrophage will present the antigen to the T and the P lymphocytes present in the white bulb. Very important to understand this concept. Now, we should imagine the blood circulation inside the spleen. It's very important that the splenic artery will branch. This is the splenic artery, will branch into segmental vessels inside the spleen. Then these segmental vessels will be trabecular vessels. We know that the spleen have a capsule and a trabeculae. So will be trabecular arteries. Then what's called small central arteries. Then this is a central artery. It's a small one. The central artery will pass through the white bulb, surrounded by the lymphoid follicle and germinal center. And then after the blood passes through the white, it will reach the red bulb. So the central artery will deliver the particulate material into the white bulb, an arrangement that facilitates antibody formation in response to antigen. So please imagine this very well. Some magnification here. So the splenic will be divided into trabecular, and the trabecular will be segmental to supply the different segments. And finally, the central artery or arteriole. The central artery will pass through the lymphoid follicle in the white bulb of the spleen. What happened here is that the antigen-presenting cells, if this blood contains any virus, any bacteria, or particulate material, rapidly it will be presented to the T cell. And the T cell will start a cascade of activating cytokines, activating the B lymphocytes, and then antibodies will be formed, and there is opsonization or tagging of this virus or bacteria, and identifications by other immune system, by the macrophage to engulf this virus or bacteria and to be destroyed inside the spleen. So here, the red bulb will receive the blood after it passes through the white bulb. Very important. So the question now, what about the splenic functions? The main functions of the spleen is related to, it plays an important role in the immune system. It plays an important role as a mechanical filtration. It plays an important role as a reservoir functions for the blood in the trauma, maybe reservoir for other platelets or white PCs. Let's start to speak about the immune function of the spleen. Spleen is the largest important lymphoid organ on the bloodstream. What mean by the lymphoid organ? It's organ where the leukocytes or the white PCs circulate and maturate and differentiate, proliferate, where the B and the T lymphocyte develop into mature antigen-presenting or recognizing cells. What is this? The leukocytes or the white PCs is the cells of the adaptive immune system. These cells is formed at first in bone marrow and other tissues. However, they are formed immature. No memory for viruses or bacteria. These cells, B and T lymphocytes, need to go to certain organs in the lymphoid system through the lymphatic systems go to these organs to become mature, to become differentiate, to expand, to identify the viruses and form the memory cells. Let's see. This is a rapid revision of the immunity or the immune system. We know that the immunity may be innate immunity. We mean by innate or natural that is present since birth. At first, our body is protected with the physical barriers to prevent the organism from passing through it. The surface lining of the respiratory and the gut epithelium, the antimicrobial isozymes, the acidic environment in the stomach. All these are barriers for the microorganism. Then we have an innate immune cells, types of the white disease like neutrophil, mast cells, basocells, dendritic, and macrophage, natural killer. Then the complement system will be responsible in a complex process, about 20 proteins, and activate the antibodies to bind to the microbes and form a different cascades of activation. This is called an innate system, present since birth. However, there is a specific adaptive immunity, or called cellular immunity, sometimes called acquired. It's a specific immune system related to the what's called B and T lymphocytes. It's types of the white BCs. However, the P lymphocyte is responsible for humoral immunity related to antibody formation. The B lymphocyte will be changed or converted into the plasma cell. Plasma cells will form an antibody specific for the microbe or virus and will form memory T cells for the second infection. So if second infection happen, this memory cell will attack rapidly the virus because already present in the memory. And there is a T lymphocytes. T lymphocytes function is to kill the infected cells, recognize, engulf the cells, and kill it. And we have a helper, cytotoxic, and memory cells. So this scheme is very important. The question now is where P and T lymphocyte formed and maturate and become well organized and become expanded. So the second is very important, the lymphoid system. Lymphoid system is responsible for the production and maturation of the lymphocyte. We have a lymphoid organ and diffuse lymphoid tissue. We speak about the lymphoid organs. The organs may be primary or secondary. Primary produce T and P lymphocyte independent of the antigen, produce immature T and P lymphocyte into the circulation, produce like the fetal liver, like the bone marrow, and the thymus. However, these T and P lymphocyte need to be learned, need to be expanded. So there is a secondary lymphoid organ. Here, the T and P lymphocyte are expanded due to antigen exposure, producing the memory T cells, the effector B cells, and the plasma cells. Where these happen? In the lymph node and the spleen and the tonsils. So this is the production and this is the activation. Without activation and identification of the viruses, the immune system cannot work or it will be very weak. So please know the role of the spleen in the child is to fight infections, is to make the T and P lymphocytes mature, recognize our different organisms. So please take care. When you need to remove the spleen, you will remove an important part of the immune system. And this child will be susceptible to large number of viruses and bacteria. So to summarize, let's imagine the role of the spleen in the immune response. Actually, mainly this occurs in the white bulb of the spleen. Imagine that the blood here contains a virus. So, and this is the white bulb, this is the marginal zone, and here we are inside the white bulb, and this is the lymphoid follicle. What happened? These viruses will, or the antigen will be presented by the antigen presenting cells, like the dendritic cells, to the T lymphocyte present where in the periarterial lymphoid sheath, PALS. So the antigen will be taken by these dendritic cells, and the dendritic will present this antigen to the T lymphocyte. The T lymphocyte identified that this antigen is foreigner, that this antigen is harmful to the body. So the T lymphocytes will get activated, release cytokines, and activate the B lymphocyte. So after that, the B lymphocyte will be activated. The B lymphocyte will be divided in two important parts. Plasma cell, which will produce an antibodies for this virus or bacteria, and also memory B cells for the second infection to fasten the response in the second time, not take all this process in the second time. So you can imagine the virus is passing through the blood, the splenic artery, and the small vessels passing through the white bulb. The dendritic cells take the antigen, presenting it to the T cells. T cells get activated, release cytokines, and then activate the B cells. B cells change it into the plasma cells and also change it into memory, a brand for this virus. So if second infection happened, already the antibodies is present and the process will be very rapid. The mechanical filtration is very important here also in the red bulb of the spleen. After the blood passes through the white bulb and the immune response happen, the red bulb will destroy old or defective cells. We speak about that. There is an open circulation or open movement of the blood, and for this blood to return to the circulation should pass through the splenic sinusoid. And we said that this sinusoid have a fenestration or slits, narrow slits, need to the RBCs to be very healthy to can accommodate the shape and pass through the circulation again. So red bulb will destroy the old and defective cells, remove some nuclear remnant and some denaturated hemoglobin. And these particles are noted on the peripheral smear after splenectomy. So after splenectomy, these particles will pass again to the circulation. So you can detect them in the peripheral smear with laboratory finding as an indication that there is no spleen. So the red bulb is very important. Also, this is very important, the red bulb macrophage. We have a process called opsonization. What's opsonization? We said that this is the virus or antigen surrounded by the antibodies. So like here in the picture, you can imagine, or in a simple word, it's coating a pill with the sugar to make it more taster. So when you have a pill with this pill is not tasty or with bad taste, you can coat this pill with some sugar so you can swallow this pill. Here, like the same idea. The antigen will be coated with antibodies. And so these antibodies act as a signals, or this coating or opsonization as a signals for the immune system. So the immune system will activate it. And here the macrophage will engulf this pill coated with the sugar. So it's very important to understand this, that this red bulb macrophage responsible for production of some opsons and also phagocytosing these opsonized bacteria, especially the encapsulated bacteria. What we mean by encapsulated? It's surrounded by the polysaccharides, capsule. Bacteria surrounded by polysaccharides so they can escape the immune system. It's very important. It's very important for all pediatric surgeons to understand this point very well. So the opsonized bacteria will be trapped here, and the opsonization will be happen here inside the red bulb of the spleen. So to summarize, you can put these items in front of you. The role of the spleen in the immunity may be summarized into number one, maturation and expansions of the T and B lymphocytes, which are already present, however, they are immature. So they will be developed and learned about the different viruses, take a print of different viruses with a memory cell. Production of the memory cells and the effector B cells, phagocytosing the opsonized bacteria, like the encapsulated bacteria, bacteria encased by the polysaccharide capsule to avoid the phagocytosis. However, inside the spleen, these encapsulated bacteria will be encased with antibodies and will be opsonized, so they can remove from the bloodstream. So what's your decision about the importance of the immune system related to the splenic function? Spleen play an important role for preventing encapsulated bacteria infection, and we will speak about its types later. These encapsulated bacteria after splenectomy will be present in the circulation, may make serious infection. However, with the development of the vaccination and antibiotic prophylaxis, this rate of infection is already decreased, however, is still present. So please don't remove the spleen and try to preserve it except if it indicated. Now we will speak about the indication for the splenectomy. When the pediatric surgeon asks to remove the spleen, there is many indications. However, here we will speak about the main indication. The indication may be divided into hematological disorders or diseases in the infant and children, like what's called hereditary spherocytosis, immune cytopenic purpura, sickle cell disease, thalassemia, and Gaucher disease. Others may be related to the splenic mass, cystic lesions, trauma, infarct, wandering spleen. All this might lead the pediatric surgeon to remove the spleen. Hereditary spherocytosis, we will speak rapidly about the idea. What's hereditary spherocytosis? It's a defect in the red cell protein. It's related to poorly deformable spherocyte RBCs instead of the normal biconcave shape. So here the RBCs is a rigid sphere due to defect, which is a common inherited dominant condition. So here these rigid spherocytes will be trapped in the spleen. They cannot pass through the fenestrated sinusoid. They cannot pass through the slits in the splenic sinusoid. As we said, these slits need normal RBCs so they can modulate their shape and pass through the slits of the sinusoid. The affected children will have a degree of hemolysis, destruction, because the spleen will destroy these abnormal RBCs with different degree of anemia. Elevated reticulocyte and elevated bilirubin from the destructions, and also the productions of the RBC, the bone marrow trying to increase its work. Some children can develop what's called aplastic crisis, especially with parvovirus infection. There is a suppression of the bone marrow, red cell production. There is ongoing splenic red destruction. So imagine destruction in the spleen and the stoppage of the production of the RBCs. The diagnosis usually on finding spherocyte on the peripheral smear with positive osmotic fragility, and splenomegaly is very common in these children. The gallstones usually present because due to hemolysis and there is precipitations inside the gallbladder. So there is a gallstones which is very common, and you should perform an ultrasound in these children. The question is how to treat hereditary spherocytosis. We should know very well the role of the splenectomy, and we should know whether to perform total splenectomy or partial splenectomy to preserve some spleen for its important immune role. And we should ask a question: if there is a need for synchronous cholecystectomy at the time of the splenectomy, is it important or is it a must to remove the gallbladder at the same session? And you can know the reverse or the opposite. when you faced with a case per child presenting with a biliary problem, is it important for hereditary spherocytosis to remove the spleen at the same session? Let's see. Role of the splenectomy. The splenectomy can be beneficial in the treatment of hereditary spherocytosis, particularly for the moderate to severe cases, while it doesn't cure the underlying genetic conditions. Splenectomy doesn't cure these conditions. However, it will improve the clinical outcome. Why? By reducing the hemolysis, because these spherocytes will be destroyed in the spleen, so you remove the spleen, so destruction is decreased. And also the complication of destructions related to the gallstones, related to increase in the reticulocytes, related to increase in the bilirubin. So you can decrease the destructions and the complications. So this is the role of the splenectomy. There is an important table for the indications of the splenectomy in hereditary spherocytosis, depending on the severity of the case, severe, moderate, or mild, the parameters of the hemoglobin, the reticulocyte, the bilirubin. So the indication here indicated but delayed until more than 6 years of age. There's a relationship between splenectomy and the age of the child, and we will discuss. However, in the moderate cases, it's individually tailored based on the spleen size and the quality of the parameters. If we have a mild case, usually splenectomy not indicated. Now the question, total or partial splenectomy? Total to remove the whole spleen, or partial splenectomy to remove part of the spleen and leave part for the immune system? Total usually performed for the moderate to severe anemia, as we said. If possible, the splenectomy is delayed until the 5 to 6 years of age to decrease the risk of what's called overwhelming post-splenectomy infection. Abbreviation is OPSI. It's very important. On the other side, there is a partial splenectomy. It is an attractive alternative to the pediatric surgeon to remove the enough spleen to control anemia while preserving immune function of the spleen. Sometimes it improves the total hemoglobin, reduce hemolysis, but not as total splenectomy. It may be useful in young children, but the long-term immunological benefit is still unknown well. So there is two schools, total versus partial in the treatment of hereditary spherocytosis. The need for synchronous cholecystectomy to perform cholecystectomy at the same time. The presence of the gallstones in the children with hereditary spherocytosis reported to be about 27% of the children younger than 10 years, and maybe 56% in the children 10 years of older. So if you perform a splenectomy and the ultrasound confirm the presence of the gallstones, you will remove the gallbladder at the same time. However, alternatively, review of the hereditary spherocytosis patient undergoing cholecystectomy for biliary symptoms suggested that these patients don't necessarily need synchronous splenectomy unless there are indications for splenectomy at that time. So the matter is different. If you face a child with a spleen enlargement in hereditary spherocytosis and destructions, and with the gallstones, you can remove the gallbladder at the same time. However, if the opposite happens, you are faced with a biliary problem and the spleen is normal, is a mild case, you don't need to remove the spleen except if there is indication, because the spleen is the part of the immune system, play an important role. The second item in the hematological indication is what's called immune thrombocytopenic purpura. Actually, many names proposed for this disease may be sometimes called idiopathic thrombocytopenic purpura. It's due to what's antiplatelet autoantibodies by the immune system. These autoantibodies will be targeted and removed by the macrophage in the spleen. as we said, the red bulb macrophage. So this opsonized the attachment of the platelet to the antibodies will form opson. So this opson will be phagocytosed by the macrophage and will be destroyed. So there will be thrombocytopenia. It may be primary condition or idiopathic in most children, may be secondary to infection or malignancy sometimes. How to treat immune or idiopathic thrombocytopenic burn? We may have a medical management to stop these autoantibodies and this immune reaction. We should speak about the role of the splenectomy, and we will speak about the further recent survey. Medical treatment of ITP. Most children with acute attack will improve with this medical management. The most treatment target plan is to decrease the platelet destruction. How? With corticosteroids, it will inhibit the binding of the platelet and the antibody complexes, so decrease their destruction in the spleen. With intravenous immunoglobulin, inhibit the receptor binding of the platelet to the macrophage inside the spleen. And also with our HOD-IG in the Rh positive will bind to the RBCs to saturate the splenic receptors, allow the platelet to avoid the destructions. So this is a medical treatment, medical management. Some children with this medical management may fail to respond or may develop a relapse. So we should know the rule of the splenectomy here, to remove the spleen, as the spleen is the site of the destructions of the platelet. Rule of the splenectomy. Number one, removing the primary site of the platelet destruction, yes. Removing important sites of antiplatelet antibody production, opson formations, yes. Splenectomy shown to be a more cost-effective and durable treatment than the medical management for the children who progress to the chronic ITP. What's meant by the chronic? Thrombocytopenia for longer than 6 months, called chronic ITP. So the different studies and pediatric surgeons show that the splenectomy is more durable than to place the child on corticosteroids and its complications. The question now, is the response or improvement with corticosteroids or the medical management a predictor of the successful outcome with splenectomy? So if the child improves on the medical management, you can guarantee that this child will improve more with splenectomy. The classic answer is the response or the improvement to the corticosteroids or intravenous IgG immunoglobulin treatment or both sought to be an excellent predictor of successful outcome after splenectomy. It sought to be an excellent predictor. So previously pediatric surgeon considered that the improvement with medical treatment is an excellent predictor that this child will improve after undergoing splenectomy. However, there is some studies related to this topic. The Wood et al. In the study of about 19 children couldn't identify this positive correlation between the preoperative medical management and the response to splenectomy. However, or in fact, they found inverse relationship between the preoperative steroid response and the response to splenectomy, with all steroid non-responders being complete responders to splenectomy. What? Yes. They reported in their paper this, that all non-responders to the steroids become responders to the splenectomy, unlike the usual answer that the response to the medical treatment is an excellent predictor to splenectomy. You need more evidence? Yes, I need. In a similar study of about 37 children with ITP, 8 of them with no response to the steroids. 8 of them showed no response to steroids. From these 8, 6 had a complete response to splenectomy, and the child improved. and 2 had a partial response to splenectomy. So the authors suggest that the failure to respond to steroids shouldn't preclude or prevent splenectomy as a definitive therapy. Very important to be understood for all pediatric surgeons that the medical treatment failure shouldn't preclude or prevent splenectomy as the second definitive treatment for the ITP patient. Further therapy, there is a trial of what's called rituximab monoclonal antibodies against the CD20 positive B cells. This will act to deplete the B cells inside the spleen. These B cells, B lymphocytes, producing the antiplatelet autoantibodies. So it's somewhat called a medical splenectomy. However, recent studies suggest that splenectomy may be more durable second-line treatment option than the rituximab for the ITP treatment in adults who fail initial medical management. There is some authors try to give the child what's called thrombopoietic agent to increase the productions of the platelet, because the productions is already decreased, usually decreasing the ITP. So they work on the weight of the increasing productions. Medications stimulate productions of the platelet or the thrombocytes in the bone marrow. They work by binding and activating the thrombopoietin receptors on the megakaryocytes, which is the mother cells for formations of the blood element, and successful therapy with this agent has been reported in some literatures. A follow-up report in the adult noted that those treated with this stimulating agent had a higher rate of platelet response, lower incidence of needing splenectomy than those treated with non-operative or medical management. The other treatment modalities may include azathioprine, cyclophosphamide, tenazole, as trying to eliminate these immunological distractions that happen inside the spleen. Accessory spleen or residual splenic tissue has been identified in up to 50% of the adult patient with ITP. So when you remove the spleen in the conditions of the ITP, you need to remove the spleen, and you should search for the presence of the accessory spleens. Because if you miss an accessory spleen, the pathology of the primary disease will return, and this accessory spleen will distract the platelet and enlarge in size and act like the primary spleen. So it's very important to detect accessory spleen at exploration. It's to avoid the parenchymal disruption of the spleen, especially when you perform the surgery laparoscopically. So if you disrupt the parenchyma and there is dissemination of the splenic tissue, so there is maybe what's called symptomatic splenosis. There is implantations of the splenic parts, and this will distract the platelet again, and the child will not improve. Very important. In ITB, you must remove the spleen, search for accessory spleens and remove it. Don't disrupt the parenchyma of the spleen to avoid symptomatic splenosis and dissemination of the splenic tissues inside and the return of the same pathology. Now we will shift to speak about the sickle cell disease. You should understand hereditary spherocytosis, ITP, immune cytopenic purpura, and the third one is sickle cell disease. What is this? It's a hematological indications for splenectomy, partial or total, laparoscopic or open. We will speak about this. Sickle cell disease. What's sickle cell disease? It's a hereditary hemoglobinopathy. It's result from amino acid substitution in the beta chain of the hemoglobin A, resulting in the synthesis of the pathological hemoglobin. Both hemoglobin 2 chains. So there is maybe problem inside the globulin arrangement of the chain of this hemoglobin, leading to formation of pathological hemoglobin S, and the RBCs will take the form of the sickled shaped instead of the normal biconcave. The red blood cell become rigid and sickled when they pass through the hypoxic environment of the spleen. So when this child exposed to hypoxia, there is a sickling of the RBCs, and these rigid RBCs will be trapped, will lead to occlusions of the vessels, vascular occlusions, and intravascular sickling, impaired blood flow to the spleen and maybe other organs. So this sickling means that when this child exposed to certain factors, these RBCs will get sickled, will be impacted inside the blood vessels, lead to vasoocclusions and impaired blood flow. With ischemic reperfusion, when the blood flow returns, there is injury called reperfusion injury. So one can assume that if the sickling happens in the spleen will become auto-infarct and atrophied, lead to functional, what's called asplenic state. However, some children may develop symptomatic sequestration. So the pathology here is that this abnormal red blood cell with abnormal hemoglobin S is rigid, will become rigid when they pass through the hypoxic environment of the spleen, or if the child exposed to hypoxia, leading to the splenic sequestration, trapping of these abnormal RBCs with vascular occlusions of the blood vessels inside the spleen. So there is maybe infarction of the spleen anatomy. However, the problem is with the sequestration. There is maybe acute sequestration crisis. The condition will not pass very easily. There will be presented with splenic enlargement, decrease of the hemoglobin due to distractions, maybe reach below the 2 grams per deciliter, maybe high reticulocyte count, maybe acute splenic sequestration crisis is an important life-threatening condition. Still, yes. Yes, it's still a life-threatening, despite vaccination, despite neonatal screening, despite paternal educations, educate them, the parent about this problem. Despite all this, is still considered as a life-threatening complication. So please, sickle cell disease is very important. The clinical management of such crisis is the rapid corrections of the hypovolemic shock by infusion of the crystalloids and packed RBCs. Splenectomy usually recommended after 2 crises requiring urgent transfusion. We will speak about the indication. So you should understand the pathology, what happened for the abnormal hemoglobin, or what happened to the hemoglobin S, and there will be a sickling, and the condition lead to sickling, vascular occlusion, obstruction, infarction. Indication for splenectomy is 2 acute splenic sequestration crises requiring urgent transfusions. So you need to remove the spleen, massive splenomegaly, and or hypersplenism. The spleen get very large, destroy all the element of the blood, destruct the RBCs, the platelet, the white BCs, and there is what's called pancytopenia. The transfusion in such cases is often ineffective because of the red cell destructions in the enlarged spleen. The spleen will become a large hole for the destructions of the all blood elements. So here you should remove the spleen if you have a 2 acute splenic sequestration crisis requiring urgent transfusion, if you have massive splenomegaly and or hypersplenism. The role of the splenectomy. What's the role of the splenectomy? When we remove the spleen, what happens? Although the splenectomy is a treatment for recurrent acute sequestration crisis and hypersplenism, there is no evidence that it increases hemoglobin level or decrease hemolysis or improve patient survival, because the sickling may happen inside other blood vessels, other organs, if the child is exposed to certain circumstances. Splenectomy may increase the incidence of the thromboembolism, pulmonary arterial hypertension, or pain frequency in the sickle cell disease. So after splenectomy, already we may have a condition of what's called thrombocytosis. There is increased platelet in the circulation. So splenectomy may increase the incidence of the thromboembolism in such sickle cell disease patient, may lead to pulmonary arterial hypertension or bend frequency. So you should understand the role of the splenectomy in sickle cell disease. You perform splenectomy by indication in the sickle cells to attacks of the sequestration crisis, massive spleen or massive splenomegaly with hypersplenism. The laparoscopic splenectomy is generally used in children with sickle cell disease. It's performed after the pre-operative transfusions or exchange to decrease percentage of the hemoglobin S. The major limitation for the laparoscopic approach in sickle cell patient is, number one, the size of the spleen. Splenomegaly, huge splenomegaly, with its local adhesions because of multiple infarction of the spleen, auto-infarction, adhesion. So with laparoscopy, splenectomy may be difficult. The longer duration of the surgery with the risk for thromboembolism, the incidence of post-operative severe acute sickle cell-related complications, including acute chest syndrome, is still unclear. So laparoscopic splenectomy is not preferred in the sickle cell disease, except with an experienced surgeon and can perform the surgery in a reasonable time. Thalassemia. So we speak about hereditary spherocytosis, ITP, and sickle cell disease. And we'll speak about thalassemia. What's thalassemia? It's blood disease characterized by decreased or absent senses of one or more of the normal globin, a chain, alpha or beta chain of the hemoglobin, and called, according to the defect, alpha thalassemia, beta thalassemia. The thalassemia major or beta is associated with the most severe clinical anemia, ineffective erythropoiesis and the chronic anemia, and hemolysis and the gallstones, dysregulated iron metabolism, and iron overload. And after iron overload, accumulation of iron may lead to organ failure. So here, there will be decrease or absence of the senses of the one or more of the normal globin. So there is what's called ineffective erythropoiesis. What's meant? There is an RBCs, but not capable of carrying oxygen. It's defective RBCs. Cannot carry oxygen very well. So there is anemia, chronic anemia, because there is these RBCs, this is malformed RBCs with abnormal hemoglobin cannot carry the oxygen probably to the tissues. So this child may have chronic anemia. Already these abnormal RBCs also will be distracted, destroyed, hemolysis, and form gallstones. Destroyed RBCs will release an iron, and so there is an iron overload, will be precipitated in the tissues and may end with an organ failure. You should understand the pathology of the disease, what happened, to understand the role of the splenectomy. Splenectomy, total or partial, preferred to decrease the need of the transfusion in children with severe anemia, because the spleen is the site of the destructions of the RBCs for the thalassaemic cases. There is what's called certain disease called Gaucher disease. It's a disease resulting from excessive accumulation of what's called glucocerebrosidase. Glucocerebrosidase is a molecule formed of the fatty acid and ceramide linked to the glucose. Fatty acid, ceramide linked to glucose in the macrophage of the spleen and bone marrow. Why this component or particle is accumulated? Due to deficiency of the enzymes called the beta-glucocerebrosidase, and this enzyme is responsible to break down this component into the ceramide and the glucose. Absent of these enzymes will lead to this fatty precipitation. It's a fat molecule with fatty precipitations in the spleen and liver and the bone marrow. The role of the splenectomy, partial or total, is to elevate the symptomatic hypersplenism, to decrease the destructions of the red blood cells, leukocytes, and platelet by the hypersplenism. However, regarding the partial splenectomy, reported one case reported massive bleeding and regrowth of the spleen, and this reported several months post-operatively in a child with Gaucher's disease who underwent partial splenectomy due to regrowth. Very important to understand well the hematological indications and the role of the splenectomy in such condition. Now we will speak about the surgical approaches for splenectomy. Pediatric surgeon have an open splenectomy technique, laparoscopic, single incision, laparoscopic splenectomy, partial splenectomy. Let's see. Open splenectomy usually reserved for the massive splenomegaly or depend on the surgeon experience. It's like to perform a left upper quadrant incisions and then followed by the divisions of the ligament, ligations of the short gastric, and searching for accessory spleen, ligations of the splenic pedicles and blood supply. Sometimes some surgeons may need to perform a muscle splitting approach to perform this approach reported with 2.7 days length of the stay, which is comparable for those with some early laparoscopic series, but longer than the recent series. Laparoscopic splenectomy. It's a preferred approach for elective splenectomy today. All of us know the advantage of laparoscopy: less pain, shorter hospitalization, faster return to activity, smaller incision. However, it's associated with a longer operative time, especially during the learning curve, and can be difficult in the patient with a splenomegaly. And we will speak about the limitations of laparoscopy. The most significant initial concern for the laparoscopic approach is accessory spleen detection. Laparoscopy may miss accessory spleen and will lead to return of the primary pathology for which the spleen is removed. So you don't make anything. However, in adult studies and some comparison pediatric series, there is a similar rate of accessory spleen detection at laparoscopy and open splenectomy. So some studies show that there is similarity between the detection if you perform the surgery laparoscopic or open. We will present some hints about the laparoscopic splenectomy. This is the initial position of the patient. You elevate the left side and with the stable table, and then you tilt the table to the left to make near supine to insert the board, and after that you will rotate the patient back to the right to reach the right decubitus position. This is the final position for the operation. Incisions and board placement, we may have two configurations. You may perform 3 small incisions in the midline, the largest used in the umbilicus, and the back of the spleen can be extracted through this umbilicus. Or you may perform 2 incisions here and a third one in the left lower quadrant for the insertions of the ultrasonic device. So this may be another or second configuration, and this is usually performed in the young children and patients with small spleens. Here, the instrument is introduced without trochers because directly through the abdominal wall, because this instrument will not be removed all over the surgery. The upper midline inserted without cannula because these are not removed during the procedure. So the pediatric surgeon can choose between the first or the second and choose between to perform the surgery from the side of the patient or stand between the legs of the patient, the French position. The laparoscopic approach is not applicable for the traumatic splenic injuries. Yes, because this child who required operation usually unstable and need rapid control of the bleeding. However, there is one report described laparoscopic, however, after splenic artery embolization in a 15-year girl with a traumatic injury. Single incisions, also we may have 2 configurations, the reported multi-instrument port, 3 or 4 channels, and we may face with separate facial incisions in the umbilicus with raising skin flap. So you may work with this already performed port, or we may work with multiple incisions in the after rising skin flaps in the umbilicus. Some surgeons recommending not to use the single incisions in the large patient with splenomegaly because the procedure will be difficult and take a longer time. Some surgeons may extend the umbilical incision at the end and to remove the spleen intact, and this will diminish the benefit of single incision laparoscopic approach. Why you perform single incision and you will extend the incisions. Like some pediatric surgeon perform laparoscopic splenectomy and then remove the spleen through finished teal incision, through a large incision. So what are the benefits for laparoscopy if you make a long incision to extract or remove the spleen? Sims et al. Noted that the need for an additional port after placement of the multi-channel port was predominantly affected by the number of the channel in the multi-port, 3 or 4. At least 4 port is preferred than the 3 channels. So you need a single incision port with 4 channels. Otherwise, you may need to insert another port or separate port. It's not affected by the patient factors, the age, the body mass index, or weight. However, it's significantly affected by the spleen size. So it's a study about the use of the additional port beside the single port. Is it important or not? Also, the authors recognize that no splenectomies were completed in their study using 3 channel alone. As a result, they recommend using 4-channel multi-port for all single incision laparoscopic splenectomy. Finally, several authors described using standard laparoscopic instrument and not needing the articulating graspers for during single incision laparoscopic splenectomy. Regarding partial splenectomy, we said that you may remove a part of the spleen. The concern about the post-splenectomy infection has led the pediatric surgeon to think about partial splenectomy. We can remove about 85 to 95% of the spleen and preserving about 25 of the normal splenic tissue. This partial splenectomy utilized primarily in the children with hereditary spherocytosis. However, may be useful for the cultures disease, hypersplenism, cystic fibrotic splenic hamartomas, and splenic cyst. So the concept of partial splenectomy. So now, how to perform the partial splenectomy? Surgical techniques. You should leave a remnant or part of the spleen with a blood supply to avoid ischemia for this part or infarction. So you may have to perform to leave the remnant spleen supplied by the segmental hilar vessels. Some hilar vessels, as we know that the splenic artery have a different configurations and divisions inside the spleen with a different segmentation. So you may leave the part with as supplied by segmental hilar vessels, maybe upper or lower, as these 2 images, upper hilar vessels or lower hilar vessels, branches from the main pedicle supplying the spleen. You leave these branches intact, or you may leave the remnant of the spleen to be supplied by the short gastric vessels only, short gastric vessels, or you may leave the remnant to be supplied by the left gastroeploid. So you must decide the remnant spleen, what's the blood supply for the remnant spleen. It's very important to be understood by all pediatric surgeons. The splenic parenchyma can be divided with a stapler, cautery, or energy device, and often with a topical agent placed over the cut surface to avoid bleeding. After you perform devascularization, a clear line of the demarcation is usually noted and the spleen divided about 1 cm onto the ischemic side to minimize the bleeding. The upper splenorenal and splenophrenic ligament are left intact to avoid the torsion of this part of the spleen. Some authors suture the remaining parenchyma to the lateral abdominal wall near the diaphragm when the vascular anatomy required preservation of the lower pool vasculature rather than the upper pool. What happened after partial splenectomy? Number one, there are several series noted after partial splenectomy for hereditary spherocytosis. There is increase in the red cell half-life. There is high hemoglobin level and low reticulocyte bilirubin, normal level of IgM and IgG, lack of the whole jolly bodies on the peripheral smear, and decreased numbers of the pitted red cells as evidence of the preservation of the splenic phagocytic function. So there is still some spleen to phagocytosis abnormal element of the RBCs. Also, what about the cholecysis after the partial splenectomy? It varies in the literature from about 7 to 22, indicating there is still ongoing hemolysis. Moreover, the need for subsequent total splenectomy is reported in the literatures by some authors. Also, splenic regenerations occur in all patients, although the degree of the regrowth doesn't correlate with hemolysis. So this is very important to understood about the partial splenectomy. You take a benefit, however, you should know what's the drawback. Rice et al. Summarized their experience in about 29 children undergoing partial splenectomy. They noted decreased transfusion requirement after partial splenectomy, elevation of the splenic sequestration, and also higher hematocrit and lower reticulocyte count and bilirubin. A multi-institutional study of 62 children undergoing partial splenectomy notes that the mean hemoglobin is increased and the reticulocyte decreased. Another report undergoing laparoscopic partial splenectomy observed improved hemoglobin level and decreased reticulocyte count because you improve the pathology or the problem of the destruction. The second multi-center series also noted no need for subsequent total splenectomy with an average follow-up from 4 to 53, the range of the follow-up post-surgery. Recent comparative study found that the laparoscopic partial splenectomy patient had a more pain, longer hospitalization than the open partial splenectomy. Also, some authors noted increased hospitalization with a laparoscopic partial splenectomy when compared to open operation. It may be difficult to perform laparoscopically and take a longer time. Now we will speak an important issue, which is a controversy related to the laparoscopic splenectomy. All pediatric surgeons nowadays are willing to perform laparoscopic splenectomy. However, there is a controversy in the literature regarding to the accessory spleen detection, the management with splenomegaly, how to deal with splenomegaly using laparoscopy, the conversion to open, what about the rate of conversion, the operative time. What's about your operative time to perform laparoscopic splenectomy, the post-operative hospitalization? Accessory spleen detection, the presence of the residual splenic functions in up to 50% of the selected adult after laparoscopic splenectomy has led to the concept about the ability to adequately detect the accessory spleen at laparoscopy. What mean by this? We mean that in the literature, they found residual splenic functions after surgery. They found after laparoscopic splenectomy, there is still hemolysis. There is still decrease in the RBCs, increase in the reticulocyte. So they think that there is maybe missed accessory spleen. And there is a debate between pediatric and adult surgeon about this item. There is a report of the equivalent detection rate of the accessory spleen between the open and laparoscopic. Also, several pediatric comparative series found that the accessory spleen detection is at 20.3% with open versus 20.2% at laparoscopy. So the laparoscopic removal of the missed accessory spleen has been reported with a good success and efficacy in the accessory splenectomy in improving ITP. So there is a debate about the accessory spleen detection. The management of the splenomegaly. How to deal with massive enlargement of the spleen with laparoscopy. The optimal management is still controversial, and most literatures related to the adult. The benefit of the laparoscopic technique has been demonstrated with a spleen in adult papers with a spleen between 15 and 25 cm. And there is what's called hand-assisted procedures have been utilized in the adult with a massive splenomegaly after devascularization, small incision, and the surgeon introduced hand to extract and manipulate the spleen. In one report, there is a 7 cm right subcostal incisions for hand access. In another report, hand-assisted laparoscopic technique, when compared to the open, resulted in a less blood loss and shorter length of stay. A recent study in the adult with a massive splenomegaly, and they determined the massive as a length more than 17 and the weight more than 600, and the supramassive usually related to the tumors, which is very rare actually in children. Splenomegaly more than 22 or weight more than 1,600 grams compared to open, found that with the laparoscopy there is a lower blood loss, shorter hospitalization, longer operative time with a 25 conversion rate, mostly from bleeding. So this study studied the deal with a massive and supramassive spleen with laparoscopy. The third controversy is about the conversion to open. It's reported in about 1.3 to 2.8 in children, and the main reasons may be related to the splenomegaly, bleeding, and the largest pediatric series documented a 1.7 rate of conversion. It's not a failure, it's a conversion. Higher conversion rate reported with the largest spleen, less surgeon experience, and obese patient. And there is a large multicentric Italian registry study of about 676 adult patients undergoing laparoscopic splenectomy and finding that the BMI and the hematological malignancy were independent predictor for intraoperative complications and conversion to open. Also, the overall conversion rate in these papers will be 5.8, and the complication occurring in 17 with a bleeding in 4.5 and splenic or portal vein thrombosis in 2.1. So this debate related to the conversion to open splenectomy and the rate of this. The operative time. Regarding the operative time, actually all of pediatric surgeons know that laparoscopic splenectomy take a longer operative time. However, there is a large series over 10 years in children noted that the decrease of the operative time occurred with the learning curve. So at the start, not like the middle or the end of the training. So with time, some papers suggest that the operative time may be close to the time taken during open splenectomy. The post-operative hospitalization, there is a comparative studies in the children demonstrate lower duration with laparoscopic approach compared with the open, and ranging from 2.5 to 4.9 days for the open and 1.3 to 3.6 days for the laparoscopy. However, there is recent studies demonstrated that this post-operative hospitalization is related to the diagnosis, for which the spleen is removed, as we see for hereditary spherocytosis. It differs from the ITP and differs from the sickle cell disease. The increased length of the stay in the sickle cell disease is secondary to the higher rate of the complication. As we said, the acute chest syndrome, the splenomegaly, the adhesions. Splenomegaly itself, which is common, doesn't appear to affect the post-operative hospitalization as documented by some pediatric surgeons and some authors. Now, what about the complications of the laparoscopic splenectomy? We speak about the controversial point. Now we speak about the complication. The complications may be ALS, maybe acute chest syndrome, bleeding, maybe symptomatic splenosis or splenic or portal vein thrombosis. The most pediatric series report relatively few complications with the laparoscopic, And there is a meta-analysis of the adult and the pediatric studies and noted the complication of rate of about 15.5 for the laparoscopy, 26.6 for the open. And the laparoscopic, they documented in this meta-analysis that the laparoscopic group had fewer pulmonary wound infectious complication, but more hemorrhagic complication when the conversion for bleeding were included. The large adult comparative study comparing open versus laparoscopic approach found there is equivalent rate of what's called grade 1 and 2 complication. They define grade 1 and 2 as a minor, potentially life-threatening complication. And there is a higher grade 3 and 4. What's grade 3 and 4? Residual or lasting disability or even death with the open compared to laparoscopy. The symptomatic splenosis, as we speak about it, reported in the ITP due to rupture of the endoscopic bag with thrombocytopenia may happen 13 months after the initial laparoscopic splenectomy as documented in such study. A series of over 200 pediatric laparoscopic splenectomies found overall complication rate of about 11% with no wound infection, post-operative ileus acute chest syndrome. Complication rate were 22 in the sickle cells, and one case only 0.5 portal vein thrombosis. The splenic or portal vein thrombosis after splenectomy laparoscopically is a rare complications. A small adult study identified a 50% incidence for these thrombosis, and they suggested that the splenic weight is the strongest predictor for the thrombosis. Another prospective study identified the incidence of 4.7, and the spleen weight is over 650, and the platelet count over 6,050 to be associated with these complications or the portal vein thrombosis. This is also a different figures related to the weight, linked the weight and the percentage of the thrombosis and the weight of the spleen. The prospective series in children found about incidence of 6% with the same risk factors of the patient with a total splenic vein thrombosis over 50 were symptomatic. And this is very important, with a fever and abdominal pain, stressing on the need to evaluate for this complication, for this condition in the patient with these symptoms. So the pediatric surgeon should know that the thrombosis may present with post-operative fever and abdominal pain. And the pediatric surgeon must suspect the condition with this presentation. The Omen review with the 76 children with a splenectomy open and laparoscopically undergoing post-operative ultrasound to evaluate portal vein thrombosis. 2 patients in the laparoscopy diagnosed with portal vein thrombosis, and both patients had a hereditary spherocytosis and undergoing concomitant cholecystectomy with a longer operative time. So some authors suggested that the prolonged operative time, the prolonged pneumoperitoneum may contribute to the portal vein thrombosis in laparoscopic splenectomy cases. And most authors recommend treatment with antithrombotic and antiplatelet therapy. Finally, we will speak shortly about what's called post-splenectomy sepsis of overwhelming post-splenectomy infections, reported firstly by the King and Chook matter in the group of the 5 infants undergoing splenectomy for hereditary spherocytosis. The actual risk is difficult to determine because most of the data were accumulated before the routine use of the parenteral vaccination and antibiotics. Most authors quote current rate between 3.5 and 4.4. And some noted higher mortality in children younger than 4 years of age compared with lower in older children. So the age at removing the spleen is very important. The causative organism is likely Streptococcus pneumoniae, which has been found in more than 50% of the all infection. Pneumococcus is responsible for a 60 of all fatal infection, followed by the Haemophilus influenzae meningococcus. Although the older studies noted mortality rate of 50%, more recent study reported a rate of around 10%. Vaccination is very important and decreases this rate and antibiotic prophylaxis. There is a single study compared the two time period. First was prior to the immunization, and the second was after immunization and 100 antibiotic prophylaxis, and they noted significant decrease in the overwhelming post-splenectomy infections, both and the mortality. Also, they conclude that the age is important rate for occurrence of the post-splenectomy overwhelming infections, and the age younger than 6 years compared with above 6 years. As we see, the rate of the infection was 13.8 for those children younger than 6 age compared with 0.5 in older children. The Lotto et al. Review with their experience with long-term outcome after splenectomy. About 11 patients had overwhelming infections with a mean of 1.7 years after surgery, with 5 deaths of this group. Of these 11 patients, 10 had underlying immunological dysfunction. The most common causative organism in their study were pneumococcus. Most authors recommend: number 1, routine immunization against Streptococcus pneumoniae and influenza and meningococcus, post-operative antibiotic prophylaxis. Although the optimal length of the antibiotic prophylaxis is unclear, the highest rate of the infections appear to occur within the first 2 years. Thank you very much for your attention and this very important subject for all pediatric surgeons and pediatricians. Splenic disorder. Spleen is an important part of the immune system. It plays a role in the immune system in a mechanical filter and phagocytosing the old deformed RBCs. Also, it get rid from the opsonized bacteria or antibodies virus complex. The pediatric surgeon should understand well the indications for the splenectomy. Hematological and other indications. Hematological is very important and it varies by the diagnosis. The pediatric surgeon should know the different techniques, laparoscopic versus open splenectomy, minimally invasive or single incision laparoscopic surgery, and they should also know what's the controversies about the laparoscopy, what's the complications, what's the drawback of the partial splenectomy and the drawbacks of the total splenectomy. I hope the topic is very well and illustrated good. It's very important for our pediatric surgeon and pediatrician to understand this topic very well. And thank you very much for your attention and your follow. Thank you and see you next subject of pediatric surgery made easy. Thank you very much.